Hello everyone and welcome back to the class. So I'll be starting the class with the leftover from the task which I had given to you. That was to find out what was the problem in the class which you had, the video lecture which I had given to you, and you have pointed out all the different kinds of answers relating to the gland, maybe just the anterior diameter or the shape of the gland was wrongly spoken or something like that. That is okay. All things might not be falling into the appropriate lines, and whichever text you are following, I am not following the same text. So that is why the standard text has to be taken as the standard measurement protocol, and moreover the cadaveric and the live positions and the different aspects, the thickness, the length and the breadth, all of them, they are different in case of the living body and the cadaver also. So whatever been there mentioned in my book, I have uttered the same to you. But the main thing which I wanted you to point out was the applied anatomy part, because in case of any glands, the applied anatomy part is more important. What are the secretions which are coming out, and what are the diseases implicated in this? That is of prime importance in your answers also, whether be it anatomy or whether be it physiology. Okay. Of course, from anatomy you will come to know about the structure of the gland, about the position of the gland, about the arterial supply. So you will come to know how the surgery is being carried out and what are the things that has to be taken care of in this surgery. That is important. That is important. I don't say it is less important, but the thing at this particular semester of yours, you are supposed to know the normal things and also the disorders which are related more in case of from the physiological point of view in case of the glands. So the cortical disorders, I just wanted you to point out the cortical disorders. Like Cushing syndrome, I have not explained clearly that the Cushing syndrome is due to increased secretion from the medulla. This congenital adrenal hyperplasia, which is also called as a Cone syndrome, is due to increased secretion from the cortex. And the third thing, the Addison's disease, is due to decreased secretion from the cortex. Okay. So from the medulla, what is the thing which is secreted? It is the active compound is cortisol, and the thing which is secreted, it is the glucocorticoids. Okay. In case of increased secretion from the cortex, it is actually the mineralocorticoids. So in this case, since it is an anti-insulin kind of secretion, so there will be decreased breakdown of glucose, and so the person will be having, since the glucose is not broken down, or most of it will be converted into fat, and so this person will be fatty. This person will be totally unhealthy because of it is increasing the total amount of fat, and that will also lead to increase in the BP of this person. Okay, and so the Cushingoid facies which I have shown to you, that the person was having a moon kind of face, so that is also implicated in case of Cushing syndrome. This also happens under the influence of increased secretion from adrenocorticotropic hormone, which is a hormone which is secreted from the pituitary gland. Okay, this is clear. Now, in case of congenital adrenal hyperplasia, which is also called as a Cone syndrome, there is increased secretion from the cortex, and that is why the mineralocorticoids are involved in retention of sodium in the body in exchange of excretion of the potassium or hydrogen ions. So basically, when sodium is in excess, there is also increase in BP. Okay. So in this case, there is nothing as such related to being fatty. The other case, which is the Addison's disease, it is due to the decreased secretion from the cortex of mineralocorticoids. When I say cortex, it means mineralocorticoids. So from the mineralocorticoids, there is less secretion, and that leads to wasting of sodium ions in the urine. Sodium ions And since sodium ion is decreased, there is also decrease in the BP, and also associated with this condition you will find pigmentation, increased skin pigmentation. So this is the thing I wanted you to point out. It should be very clear. In the last class I think it was not very clear. Okay. Now advancing forward. Now advancing forward in the gland system, the next gland to discuss is the thyroid gland. We will be discussing another gland which is associated with the thyroid gland. This is the parathyroid gland. This is very much close proximity to the thyroid gland. And the next gland, which is, of course, as you already know, thyroid gland is closely associated with the thyroid cartilage. It is here, somewhere here in your neck, right? And the third one, which is the last one for discussion in the enterprise system, is the thymus gland. Because pancreas I have already discussed in the practical classroom, and I have also shown you the pancreas gland. So the thing for discussion now is the thyroid gland plus the parathyroid gland plus the thymus. So these things we will be discussing together. The first thing which we will be discussing will be the embryology part, then the next the position of the different glands, and then we will come to the histology part, and also of course we will discuss the different applied importance related to the thyroid gland and also the parathyroid and the thymus gland. Let us go to the embryology part first, because this is this is the part which is common to all these three glands. So the beauty of the thing is that once you know about the embryology of the thyroid gland, you know the embryology of the parathyroid gland also, and you know the embryology part of the thymus gland also. So let us advance forward to the embryology part. I want to show you an animation. This is an animation of the human embryo. I have already shown you this part, and this is regarding the animation specifically of the head and neck region. I have already told you that the head and neck is not formed just like that. It is formed by the branchial arches, or also called as the pharyngeal arches these days. So pharyngeal arches, they form the face region by the formation, by the fusion of the arches from both the sides. So in your face, the fusion of the arches from both the sides, they join in the middle to form your face. It was not the gut tube which you have, which is formed from the endoderm, which is shown in the yellow part here. This is basically somewhere in the lower part of the larynx, okay? And the upper part, this is formed from the neural crest cells. I have already told you. So the point which I am discussing, which I want to insist, is that this part specifically, this head and neck part, this is to be paid importance in this class. Because the thyroid and the thymus and the parathyroid, these are derived from the branchial pouches, pharyngeal pouches. Okay, I'll tell you what the pouch means, but first of all, orient yourself. This is the 4th week of development I am talking about of the human fetus. This whole human fetus, this is the human fetus. It has got a cranial pole. This is going to form the head, cranial or the head, and this is the caudal pole or the tail. Okay, so this is the cranial or the head part, this is the tail part, and this part is the body. Okay, need not to insist. I think you have been oriented. This whole thing which I am describing is the amniotic cavity, amniotic sac. Okay, these are the villi. I think you know already. You remember that there is a formation of a placenta. So placenta will be formed in the endometrial side. Okay. So these villus projections, they will form the placenta altogether, but the connection which is coming out from the embryo, it is called as the umbilical cord. So umbilical cord will be connected to this. Let me take a different ink. Say I want to denote the umbilical cord with a red ink. So this is the umbilical cord of the embryo, and the part which is missing I have drawn it. This is the umbilical cord. Okay. So this is the umbilical cord which I have drawn in this embryo, okay, which was missing in this diagram, and this one is the fetus. The whole is the fetus. So just focus on this particular area. This particular area, this is the cranial part which is called as the head, and in this the knob of the terminal knob of the neural tube is there. I think you already remember what is the neural tube. This is basically the neuroectoderm which is folded in itself in the form of a slipper shaped disc and then finally gone down below the ectoderm, which forms the entire of the CNS, that is the brain and the spinal cord. You know now already, or even if you don't know, just go through the lessons which we have discussed in the classes which were held in your college, that what is the neural tube. Okay, go through the classes. So you will find that this is there is a tube here. I will mark it in yellow because neural tube is marked with the color yellow. So there is a tube here. There is a tube here which is yellow in color, and this is the neural tube. Okay, so this is the neural tube, and the terminal part, the knob, it will form the brain. You can remember it now by now. If you do not remember, then please go through the lessons once again. Okay, and this is a lateral picture. This is the lateral view of this embryo or the growing fetus. Okay, or the growing fetus. So just imagine that this is you in intrauterine, and this is your head region, this is your body region, and this is the tail region. That is it is going to form the lower part, it is going to form the limbs, right? And the body part, it is going to form the upper limbs. This is for the lower limbs, okay, and this is the head part. So if I take a picture of yours from the lateral aspect, so this is the same picture which has been taken intrauterine. Okay, advancing forward. So this is the embryo which has been shown in a magnified view. When we see in this picture, we see the pharyngeal pouches which are found here. Okay, what is pharyngeal pouches, what is pharyngeal arches, I will show you again clearly. But before that, just don't lose your orientation on the fetus. This is the head part, okay, and this is the body part of the fetus. This is the tail part which is going to form the lower limbs, and somewhere here there will be the formation of the upper limbs. This is the fetal, this is the umbilical cord which has been cut out because it cannot be shown in this diagram. Okay, so this is the liver bud, this is the lung bud. Okay, all these things has been shown. So let us advance forward. So when the fetus has been turned to the front, we were looking into the lateral view. Now the fetus has been turned to the front. It is looking straight in front of you, okay, straight on your face. Then what you see that this is the head region, and these are the parts which are in the lower part of the head region. That means this part, this head region is this one, okay, and the arches, the pharyngeal arches, 6 in number, these are going to form the face as a whole, downward from here. Okay, these are going to form the face, and this is the head part which has been shown as a terminal knob. This part, this terminal knob, this one, it is a head part, and these pharyngeal arches, these are shown here. Okay, let us advance forward. So when I take a section, this is a coronal section. See, you are taking a section in not the sagittal way. This is the sagittal section, you remember, and this one is the coronal section. So when you take a coronal section, you divide the body into anterior and the posterior parts. Okay, so when you take a section of the head part exclusively, what you see here, they have shaken it out, the section, and they have shown that these are the arches. Okay, so these are the arches which are going to form. Let me ink it out using black color. That these are the arches which are going to fuse in the midline, and these are going to form the face. Okay, first arch, second arch, third arch, fourth arch, fifth arch, and the sixth arch. Okay, in this way these arches, they are going to fuse in the midline, and along with it the terminal knob, which is the head, it is going to fuse with the arches, and it is going to form the whole of the face. Let me just mark one more thing. Just look at these dots and just see what is going to happen to these dots. Okay, let me advance. These dots are actually nothing but the, yes, this is called as the lens placode. This is the lens placode, and this is the nasal placode. That means the nostrils are going to be formed from this part, and lens that is the eyes are going to be formed from this part. Okay, just advance forward in this same diagram. Please be attentive while you are going on through this video. Okay, so when we advance forward, then we see somewhat it looks like this. So in this you see this is the upper part. The upper part is having this is the head region, which is going to form the brain and the spinal cord. Not the spinal cord, sorry. This is going to form the brain part. Okay, and this nostril, which was medial, you saw two markings. One was somewhere here and one was somewhere here. So from the front you can only see this marking, not this one. This is not found in the frontal view. So this is the frontal view. The fetus is looking right onto your face, front to front. Okay, in this you see only the nostrils. The lens placode is in the lateral part. It is hidden somewhere here. You will gradually see it when the fusion will take place. Then you will gradually see it. Okay, so let us advance forward. What I have already told you, that has been labeled here. See, this is the frontonasal prominence, that is the head part as well as the nasal part. Frontonasal prominence, which is seen here, which we see in the adult, this has been shown in this part. Okay, this is the nasal placode. So the nasal placodes, they are so much big in the fetus. Just imagine these nasal placodes as if they are occupying the whole of your cheek. No, it is like this in the fetus. And what you see here, this is the stomodium. They have shown this is going to form your mouth. Okay, and this mandibular process, this is the mandibular process. You know, this is the mandible, your lower jaw. So the mandibular process is this one. This is not fused. You see, in the dogs and in the lower animals, you will see that the fusion in this area is not complete. Okay, they have got separate lips. Okay, and there is a problems also relating to this. This is the cleft lip, cleft palate. All these are related to non-fusion in the midline. So this thing I want to insist, that the mandible has not fused yet. Okay, but our point of insisting in this class is not that these are the arches. Actually, mandibular is the first arch. So this is the whole of the upper part, the terminal knob, and this is the first arch. This is the second, third, like that, 6 arches. Okay. So my point of insisting is not at the formation of face. I just want to orient you to the diagram which I am seeing, we are seeing now, but to rather tell you that this mandibular arch is the first arch, and we are going to see this diagram and focus this diagram more, because the embryological part of the gland is more related to this. All the 3 glands, thyroid, parathyroid and thymus. Okay, so please pay attention at the section, the coronal section. I think you remember here that there has been a coronal section which has been taken in this part. So this is the coronal section, and this coronal section is being shown here. I think you have not lost the trail that the coronal section of the head and neck region of the fetus, this has been shown in this part, and this is the mandibular arch. This is the first arch which has been shown in this part. Okay, this is the counterpart, and exactly in the middle, what do you have inside your mouth? What do you have inside your mouth? Yes, this is the tongue. So this is the tongue, and the last part of your tongue, it has got something called as the foramen cecum. Last part, just go through the diagrams of your tongue in your textbook, or you Google in the diagrams of the tongue. The last part, you will have a V-shaped sulcus, okay, that separates the anterior 2/3 from the posterior 1/3 of the tongue, and in that V-shaped sulcus, the terminal part of the joining of the 2 arms of the V, this is called as the foramen cecum. So what we will see here now is that from this foramen cecum itself, the thyroid gland will develop and it will go down, ultimately descending to the anterior part of the neck. This is around C5, 6, 7 or C6, 7, 8 and T1. Okay, so it is over the cricoid cartilage, and the upper part of the lobes is also touching the thyroid cartilage. So the thyroid cartilage itself is named on the gland, right? The thyroid gland. So you know the position of the thyroid gland approximately. It has come right from your tongue. Okay, so this is a derivative from the terminal part of the tongue, And the parathyroid and the thymus, they are developing from these pouches. Do you see? This is the first pouch, okay, this is the second pouch, this is the third pouch, and this is the fourth pouch. So our point of insisting is that these pouches will also drop downwards in gradually, and these will form different glands. The first, leaving the first two, the third will form the third pouch, it will form the inferior parathyroid, PTH I am writing, and also the thymus. And the fourth, it is forming the superior parathyroid and nothing else. So that means that the third pouch is descending more. Third pouch is making up what? This is the third one. So third pouch, the third indentation, third one, I am showing it here, it is going much downwards. Okay, so it is going much downwards. Here in this case, see, this is the third pouch they are making. Third is descending much more than the fourth pouch, which is placed superiorly. So that is why the superior parathyroid is developing from the fourth pouch, and the inferior parathyroid is developing from the third pouch. Also, the inferior parathyroid, the third pouch, it is also giving rise to the, yes, I will use a different color. Inferior parathyroid is also giving rise to the thymus. Okay, thymus plus inferior parathyroid. So that is why in spite of the fact that inferior parathyroid, which you will think that it should be developing from the fourth pouch, it is actually developing from the third pouch, because the main aim of the third pouch is to develop the thymus. While it is going to form the thymus, some of the droppings which has been left behind the thyroid gland, this is called as the inferior parathyroid. And the fourth pouch, it is directly going for some distance, and it resides behind the thyroid gland in the form of the superior parathyroid. So let us see the picture more clearly in case of the animation. So as we advance forward, do you see that there has been so many transformations? You are seeing all these things. Let me ink it out. You have seen all these things because these, you see, these are called as the clefts. Outside the same outpouchings, these are called as the clefts. So clefts are going to form something else, okay, and the pouches are going to form something else. So the inside is going to form something else, and the outside also going to form something else. This outside, the first cleft, this is called as cleft. The outpouching on the outside is called as a cleft, and the and the pouching inside, which are formed inside in the same rings which are forming the arches. Okay, rings, arches. The inside pouchings, these are called as the pouches, and the outside are called as the clefts. So cleft, the most prominent is the formation of the external auditory meatus. And in case of pouches, yes, of course, different pouches form different things. For us, the important is the third and the fourth, and of course there is another thing which is coming out from the foramen cecum, and this is called as a, yes, this is the thyroid gland which is going to be formed. Let us see again, advance forward. So as you see that the thyroid gland, it is the thyroid gland which is formed, it is somewhere in the tongue region, intrauterine right now, okay, and these superior parathyroid and the inferior parathyroid, which is the thymus, the third one, it is going to form the inferior parathyroid, see, inferior parathyroid and the thymus, and also the superior parathyroid, these are going to drop downwards, these will advance forward. Let us focus on these things, this one, and this one, okay, just focus. This is going, they are taking another section, coronal section, and they are showing the paranasal sinuses also. Actually, this is the nasal septum, as I have already told you that there is a nasal septum, and this is the tongue region. So let us advance forward, not of much importance to us. They have taken a slice, and they have also shown here that this is the formation of the pellets, okay. So the pellets are going to be formed. So let us advance forward. This thyroid gland, it is going downwards along with the progenitor of the thymus, that is the third pharyngeal pouches, and the fourth pharyngeal pouches, they have directly come behind the thyroid gland. Did you see that? The fourth have already come here. Third is going downwards because it has to form the thymus, and the outpouching from the middle of the tongue, that is a foramen cecum. Do you see the line here? It is going to form the thyroid gland. Almost it has taken the shape of the thyroid gland. So as we drop downwards, the parathyroid has been left over, the inferior parathyroid has been left over, and the thymus has gone downwards. Okay, so this completes your part on the embryology part. Okay, will not advance forward, not of much importance to us. So once again coming back to these slides of the thyroid gland, first of all we will go through the different gross anatomical aspects of the thyroid gland. Advancing forward in the slide, the thyroid gland is located just in front of the C5, C6 and C7 vertebra and also the T1 vertebra. So basically the thyroid gland is a structure of the neck. So when we are saying about the structures of the leg, then let me tell you one thing, that there is one structure, one muscle which is present here. This is called as the sternocleidomastoid, and you must be remembering this muscle. Okay, so this is called as the sternocleidomastoid. So it is these parts which are anterior to these muscles, the sternocleidomastoid, these are considered as this triangle, it is called as the anterior triangle. So this thyroid gland, it is a bilobe structure. This is located on both the sides of the neck as in the form of two lobes, okay, and which has been joined in the midline in the form of a isthmus. So this sternocleidomastoid is the muscle which is dividing the neck into anterior and the posterior parts. In the anterior part you will be finding one of the lobes of the thyroid gland on one side. So both the sides the thyroid gland will be joining in the middle in the form of the isthmus. So this, when you consider the structure of the thyroid gland, then you have to say that this thyroid gland is a form of a conical structure. Okay, so two cones I have drawn on either side of the neck, and suppose these are the cricoid rings. Okay, this is somewhere the area of the cricoid rings. So let me ink it out, let me write down the labels, that this is the cricoid cartilage, and somewhat in the upper parts you will even find the thyroid lamina. Okay, so this is the thyroid lamina, and this particular gland, this is the thyroid gland. So both of them are present here, both the lobes of the thyroid gland. It has got one apex, it has got a base. Okay, so it has got an apex, it has got a base, and it has got two borders. One is the anterior border and one is the posterior border. So this is the anterior border and this is the posterior border. Okay, so it has got apex, it has got a base, just like you have studied about the adrenal gland, and the length of the gland is approximately 5 cm. There also it was same. Then the breadth was somewhere, it was around 4 cm. So here it is written as 3 cm. So don't catch on the things like 3-4 cm. So this is approximately 5 cm, 3 cm, and the thickness is around 2 cm. In that gland, adrenal gland, I think it was written as 1 cm. Okay, so this is basically a conical structure. Let us look at the surfaces. If I take a transverse section at this level, if I take a TS, then what will I find is, suppose this is the thyroid lamina, this is the thyroid cartilage. Okay, I will use a different ink here. So I will mark it in yellow. This is the thyroid cartilage. Okay, so what is the thyroid cartilage? I think you already know this is hyaline cartilage. Okay, so thyroid cartilage is this one. When you look at the gland at this particular level, just below the thyroid cartilage, this is the thyroid cartilage. I have drawn to orient you that there is a presence of an organ just behind the thyroid cartilage. This is the part of the larynx, right? So the part of the larynx which is related to this part, this one is, I will use a different ink in this slide. I will use a blue ink. Okay, so this part just behind the thyroid cartilage, you will find that there is the formation of the tracheal rings. Okay. So this is the formation of the trachea. This trachea is just below and behind this, the thyroid lamina. Okay, the trachea will start, and in this tracheal rings, you will find attached to it. So this is basically, I must have to erase this part, because the thyroid lamina, below that only the tracheal rings will start, right? So what I will do is, just will advance forward through the standard diagrams. First if you see in this part, I will take the transverse section. I want to take the transverse section in this part. So what will I see is, I will see the cricoid rings. This one is the cricoid ring, and just in front of that I will find the lobe of the thyroid. I will use a different ink. I will use a red color for the gland. So what will I find is that it is triangular in shape even in the transverse section. So this is the transverse section. This one is the cricoid rings. Okay. And in this you will find that there is an anterior border, there is a posterior border. This one is the posterior border. Okay, not this one. This one is the posterior border. So there is an anterolateral surface, there is a posterolateral surface, and there is a medial surface. Okay, this is regarding the thyroid gland. The thyroid gland has got an anterolateral surface, then there is a posterolateral surface, and this is the medial surface. So this is the anatomical aspect. If I have to make it more clear, I'll just show you that if this is the tracheal ring, in the same diagram that we have seen just now, these are the tracheal rings. Okay, so in this tracheal rings, these are the tracheal rings, we will find that the lobes of the thyroid are located, and in the upper part you will find the thyroid lamina. Okay, this is the thyroid lamina. The two lamina, that means the two plates are joined in the middle to form the thyroid cartilage. Okay, below that you will find the cricoid cartilage, and on both the sides you will find the gland. Okay, if you take a section at this particular level, then what you will find here is that this is the lamina of the cartilage, the thyroid cricoid cartilages, and on either sides of it you will find the gland. You will find the gland in this form, this one. Okay, so what it basically has, it has got three surfaces. This surface which is towards the cartilage, it is called as the medial surface, and it has got anterolateral and posterolateral surfaces, and this one is the anterior border, and this one is called as the posterior border. So these are the borders 1 and 2, and the surfaces, these are the, I will use a different color, I will use the black color. This is the anterolateral surface, there is a posterolateral surface also, and on the one which is facing towards the cartilage, this is the medial surface. Okay, so this completes the shape of the gland. The importance is not of the shape, as in the previous class also I have seen that you are clung up to the measurements of the gland, you are clung up to the different surfaces and the borders. That is okay, but if you are oriented well, properly oriented, then you will definitely guess what will be the names of the surfaces. The one which is facing posteriorly, this is the posterolateral. One facing anterior, this is the anterolateral, and of course this one is the lateral surface, and this one is the medial surface. So this is not somewhat you have to insist upon. The point you have to insist upon is the importance, applied importance. So what I am going to tell you now is the applied importance, which we will see in the next slide maybe. So in the next slide, you are going to see that the lobes of the thyroid gland, I have already told you that it has got two lobes on either sides, and it has got the isthmus which is joining it in the midline. Okay, the position and the structure of the gland has already been discussed, so don't go by the dimensions 5, 3, 2 cm what I have told you. This is an approximate. Okay, let us go to the important part. Of course, hormones. Before that, hormones, I just want to tell you that in a whiteboard that if you see the generalized structure of the gland, suppose this is the thyroid gland which has been joined in the middle by the isthmus, then this gland is being encapsulated. It has got covering. Okay, so the covering which is found here on the outside, this is called as the false capsule. I think you remember that there was a kind of capsule which was discussed in case of the adrenal gland also. It has got the outer capsule which is called as the false capsule, which is derived from the fascia of the neck. So in the neck we have got the names of the following fascia. Okay, so number one, in the fascias of the neck, I want to tell you that the important fascias are, number one is the buccopharyngeal fascia. One is the pretracheal fascia, and the third one is the vertebral fascia. So buccopharyngeal fascia, this fascia, it is the buccopharyngeal fascia, I am sorry, but this is present in the pharyngeal part, the posterior part. This should not have been mentioned in the first part itself, but the pretracheal fascia is the one which I want to insist upon, because this is keeping the gland in its position, and the vertebral fascia is in the posteriormost part behind, which is enclosing the muscles of the neck. These fascia are the neck fascias. Always remember, these are present in the neck region. Okay, these are the fascias which are enclosing or compartmentalizing the neck region. In addition to this, you have got the carotid fascia which is enclosing the carotid, the common carotid artery along with the internal jugular vein. This is the carotid fascia, and also overall your neck, the neck region, overall just beneath the skin, you have got one layer which is called as the investing layer. So just have a look. You don't need to cram all this up. What I want to insist here is that the carotid fascia, this fascia, and the pretracheal fascia, they are together forming the enclosing capsule of the gland. Okay, so this carotid fascia, it is enclosing the common carotid artery. The common carotid artery pulsations of which can be felt here. Okay, there was a demo of your, before taking your online assessment, first one, I have given a diagram in which there was a, I wanted to see whether you can see the images or not. So there I have shown you the photograph of a lady of whose the carotid pulsations were being tested out in this form. Okay, so basically these vessels are being protected in and have been bundled together with a fascia which is called as the carotid fascia. Okay, and there is a fascia which is present just below the trachea. Okay, in front of the just behind the trachea and the thyroid lamina. This is called as the pretracheal fascia. This fascia, it itself gives rise to some outpouchings or some form of the extensions which ultimately enclose this gland. Okay, you just remember that the gland is enclosed by a false capsule, and that false capsule is derived from deep fascia of the neck. All these are neck deep fascia. So you need not remember all these kinds of fascias, all the names of the fascias. For you, important is the false capsule is derived from the fascia of the neck, and the true capsule is actually the histological condensation of the fascia. True capsule is very much related to the gland. True capsule is within the gland, okay, and the false capsule is outside the gland. Behind the within the true capsule and the false capsule, you will find the veins. You will find all the veins in this space between. I am using a different color. So in this, the ink color I will use as blue. So between this two areas, it is a deeper blue, no? Yes. So in this area you will find the veins. Okay. So the veins are occupying the area between the false capsule and the true capsule. Let us advance forward in the slide. So in this case, the thyroid gland, one thing important that I have to tell you, that the thyroid gland is covered by thin fibrous sheath which is called as the capsule of the thyroid. The capsule of the thyroid forms the septum and divides the thyroid tissue into microscopic lobules. This thing is actually, microscopic lobules is actually, it is the true capsule they are talking about. True capsule. And this thing, this is somewhat there, they want to notify about the false capsule. As we go forward, the hormones that will be secreted in the thyroid gland is mainly the T3 and the T4 under the influence of the pituitary TSH, thyroid stimulating hormone, which is secreted by the pituitary. They are basically releasing the T3 and T4 hormones. Okay. So when we go about the histological picture of this gland, is it there? No, it is not there. So in this histological picture, what we will find here is, I will show you in the slides also, in the last part, I will show you in the slides. In the whiteboard I want to tell you that these cells, they are forming, rings, these kinds of rings, and inside the rings there is a formation of the colloid. So these rings, they are actually occupied by cuboidal oblique columnar cells. Why I am telling the cuboidal oblique columnar cells is because at the secretory phase they form columnar, means when they are metabolically active, they are columnar, they increase in size, and when there is not much of secretion, they are cuboidal. Okay. So what I am drawing here is they are cuboidal cells, and this is a thyroid follicle, and inside which you will find the colloid. Okay. This is a matrix, this is called as the colloid. Out of this, if I take the picture of one particular cell, what will I find here is that this is a cell which has got the outer side. Okay, this one is the outer side. So this is the outer side of the cell, and this was the inner side which is facing the lumen, inner side. This inner side, this one, okay, inner side which is facing the lumen. In this, iodine is being trapped. Okay, iodide form, it is trapped from outside, and iodine is released with the help of the peroxidase enzyme. And tyrosine, which is actually a protein moiety, this is being trapped, and this is being taken inside the lumen, and this is released as monoiodotyrosine and diiodotyrosine complexes. Okay, so all these things plus iodine, when iodine gets inside, these tyrosyl residues, they are being iodinated as monoiodo and diiodotyrosine. Then they are again taken up, and with the help of certain enzyme dehalogenase, this T3 and T4 are formed. Just don't go into much detail. Just remember that these are thyroglobulins. So globin, the globin protein form. This got omitted. Okay, let me draw once again. This is the cell, and this is the luminal side, and this is the base outer aspect of the cell. So inside you will find MIT plus DID, thyroglobulin and monohydrothyroglobulin. So the globulin or the globin protein that itself binds to the iodine and the tyrosyl residues. Iodine and tyrosyl residues, and the tyrosine, the protein tyrosine, it is forming all this. Okay. So whenever this MIT and DIT are they are joining together in different permutations and combination and leaving back this iodine molecule, they form, actually they are released in the form of T3 and T4. Okay, these are the two active forms of the thyroxine, which is actually secreted by this gland. Okay, the thyroid gland. Let us go forward in the applied importance part. In the applied importance part, the thyroxine secretion, the T3 and the T4, these are actually increasing the basal metabolic rate. So in a euthyroid person, this is the required amount is being secreted, and the required amount keeps on regulating all kinds of metabolic activities in the body. Okay, whenever there is a problem with the increased secretion of this T3, T4, then this is called as thyrotoxicosis. And when there is the decreased secretion, you already know what is the name, decreased secretion. Yeah, this is hypothyroid state. Okay. So hypothyroid state and the increased secretion, this is the hyperthyroid state. These are both pathological states of the increased and decreased secretions of the thyroid gland. In the applied importance, the names of which you have to remember: the hypothyroid state of children, it is called as a cretinism, and in case of the adults, the hypothyroid state is called as the myxedema. Okay. The goiter is the state in which there is an enlargement of the thyroid, basically because of the action of the thyroid stimulating hormone, but the thyroid status of the person may be normal. That means in this hypothyroid person, the T3, T4 is less, but in goiter, although there is an enlargement, the T3, T4 may be quite normal. Okay, that is the euthyroid goiter. But basically, when in the hypothyroid state also maximum, there is a formation of this multinodular goiter in which there is lesser secretion, and because of the overactivity, because of the lesser secretion of T3 and T4, there is a feedback from the pituitary that, oh, thyroid, you are not working well. So why are you not working well? I will give you much more stress. So because of the stress, there is increase in the size of the gland, but still the total T3 and T4, because there is an abnormality in the secretion, the thyroxine cannot, T3, T4 is not secreted in sufficient amount because of the problems in the gland. That is why even though the gland becomes increased in size, which is called as a goiter, but still there is not much secretion of T3 and T4 which is required for the basal metabolic functions of the body. Okay. Then in the hypothyroid state, there is a exophthalmic goiter, which is called, because the eyes, it seems like the eyes are coming out. This is because of the increased basal metabolic rate. Various mechanisms are there. You can go into much detail, but it is not required at the present time. Just remember that Graves' disease is the disease which is related to the increased secretion of the thyroid gland. Okay. So this is hyperthyroidism, and this is the point you have to remember at the present time. Okay. So moving on to the next topic, the parathyroid gland. The parathyroid gland is located just behind the thyroid gland. So the parathyroid gland is the secretion of the parathyroid gland is calcitonin. So moving forward to the different things that we have to learn about the parathyroid gland. First one is the position. As I have already told you, that the superior parathyroid gland is located at the superior pole of thyroid gland. Okay. So this is the position. This is the position of the superior pole in which the superior parathyroid is located. And you already know from embryology part that the superior parathyroid is derived from the fourth pharyngeal pouch. Okay. The location of the inferior parathyroid is variable. Some of them they are saying that the inferior parathyroid is located in the lower pole of the thyroid. Lower pole, this is easy to remember, lower pole of thyroid. And some of them they are saying that in the lower pole of the thyroid itself, it is close to this artery. This is called as the inferior thyroid artery. Inferior thyroid artery. So in certain textbooks it is written it may be close to the inferior thyroid artery. In certain textbooks it is written it is inside the true capsule. So generally both the parathyroids are supposed to be positioned between the true capsule and the false capsule. But the inferior parathyroid, it may be positioned inside the true capsule also. This is golden yellow in color, and it is difficult since it is very small. So it may be misinterpreted as this is a it is a tissue, it is a fatty tissue. That is why it may be removed. Accidentally it may be removed. So this is to be taken care of, that the superior and the inferior parathyroids, these are located in the posterior part, in the posterior border, just near the posterior border of the thyroid gland, and the superior parathyroid, which is derived from the fourth pharyngeal pouch, is superior in the superior part of the posterior surface of the posterior border of the thyroid, and in the inferior part, in the inferior lower pole, the inferior parathyroid may be located. So important thing in this parathyroid gland is not much about the position. Of course you have to know where it is located, but the secretion of the parathyroid gland is important. Simple thing is to remember that the production of parathyroid, the hormone which is produced, is called as parathyroid hormone. So very simple, the gland is parathyroid gland and the secretion is parathyroid hormone. And the function of parathyroid hormone is basically to control the levels of calcium in the blood. So what happens is, I will show you that the calcium hemostasis, that is the level of calcium that is to be present, is actually controlled by three things. Number one is parathyroid hormone, and in the microscopic anatomy, that is basically there are two cell clusters in histology of the parathyroid hormone. There are basically two cell clusters. One is the principal cell and one is the oxyphil cell. The function of oxyphil cell is not so clear, but the principal cell is related to the production of parathyroid hormone. And this, what it does is, it increases the calcium level in blood. Calcium in blood is increased at the cost of the erosion or the mobilization from the bone. So basically, when the calcium level is increased and there is no intake, though the parathyroid hormone, the bad thing is that it will basically erode the bone. It will not make the bone stronger. In fact, the bones will get weaker. And so the calcium level, no doubt, it will increase, because calcium is not only required for the bone. The calcium is required for many other muscular functions. As you already know, calcium is required for the contraction of the muscles. So calcium level has to be maintained in the blood. It is a very important ion in the blood which is present and which is in fact seen in the clinical practice in the very seriously ill patients. This is continuously monitored. So calcium that has to be mobilized from the bone is not a good practice. The good practice is that the vitamin D, which is present, synthesized in our body also in certain cases, and also it can be taken in artificial as a deficiency. It can also be taken in. What happens is, vitamin D, which is synthesized from the kidney mainly, it actually increases the absorption of calcium. So in case of kidney diseases, what happens is, automatically the calcium level they gets depleted, and with the help of parathyroid hormone, since it is automatically sensing the level of calcium in the iron in the blood, so what happens is, it will make the erosion of the bones more possible. But to antagonize this activity physiologically, there is another hormone which is secreted. This is calcitonin. This is actually secreted from parafollicular C cells. Of thyroid. So this is another cell cluster which is present in the thyroid gland itself, which I have not told you. Just remember now that the parafollicular C cells, these are a cell cluster which is very important regarding the secretion of calcitonin. And what it does is that calcitonin, when the blood level calcium is increased, then it takes the blood calcium from the blood and it again deposits it in the bone. So this is a good hormone, but the excess secretion of either the calcitonin or parathyroid hormone is bad, because excessive secretion of calcitonin will also lead to diseases, and excessive secretion of parathyroid hormone will lead to diseases, which we will see now. That the excessive secreted parathyroid gland, this is related to the regulation of the calcium, as I said, as has been already mentioned. And the hyperparathyroidism, it causes pathogenesis, that is the bone pain, because there is excessive removal of calcium from the bone. So bones will become brittle, they will become fractured also, and basically the calcium from the blood is removed from the kidneys only. So basically there is an increased chances of deposition of calcium in the kidneys in the form of kidney stones, and basically more of it is implicated in the formation of oxalate stones. So there are different kinds of stones also, you will come to know in the surgery part. So just to remember this, that parathyroid hormone in excess will lead to the mobilization of calcium from the bone, and this will result in the brittling of the bones. Hypothyroidism, in case of autoimmune disorders, there is also less secretion of parathyroid hormone. Also, as I have told you, there is a definite level of the hormone which is very important. So it is not that something which is some secretion in the gland has to be secreted in the definite amount which is normal, and anything excess will also lead to diseases, and anything which is less also will lead to diseases. This leads to formation of cataracts and muscle spasms also, since the calcium levels, just remember, calcium levels, it is required for the normal functioning of the calcium, because this has been discussed in the class how the sarcoplasmic reticulum, they are delivering the calcium into the sarcomeres, that is muscle cells, and basically the contraction is going on. Okay. Moving on to the next part, the last part, which is important from the point of view of yes, of course, I have forgotten to tell you that yes, cancers of the parathyroid hormone is also there, in which there will be overproduction and surgery and radiation therapy is done. So before leaving this, the most important part from the anatomical point of view, which is common for both thyroid and parathyroid, is this blood supply. So blood supply I have left out. So in this blood supply, the thyroid gland basically has got the blood supply from three arteries. One is the superior thyroid artery, one is the inferior thyroid artery, and one is the thyroidema artery, which is not written here because this is sometimes which is it may not be found. So basically two things which is important from here is superior thyroid artery. It is a direct branch from this artery, and this artery, it is the internal carotid artery. I think it is written somewhere here. So this is the common carotid artery. So from that, sorry, this is not the internal carotid artery, this is the external carotid artery. So just remember that the carotid artery, it is supplying the superior thyroid artery, and that superior thyroid artery is supplying the thyroid from the superior pole. The next is the inferior thyroid artery. I have marked the vein, no? Where is the artery? Inferior thyroid artery, they have not marked it. Inferior thyroid artery, that is basically coming from this. This is called as the brachiocephalic trunk or the subclavian artery. Brachiocephalic, right brachiocephalic trunk. from here there is a thyrocervical trunk, thyrocervical trunk. So from here there will be, in case of right side, there will be a, this is actually the arch of aorta. I have to guide this to this one. This is the brachiocephalic trunk, and here this is the directly the common carotid artery. So what happens is, there is a, from the brachiocephalic trunk there is an artery which is arising, which is called as the thyrocervical trunk. From the thyrocervical trunk there is the inferior parathyroid artery, which is arising. Superior thyroid artery is giving rise to the supply of the superior parathyroid gland, and inferior thyroid artery is giving rise to the supply of the inferior parathyroid gland. I think that is very easy, simple, right? So let me summarize once again, since there was a confusion. Number one is that there is superior thyroid artery which is supplying the superior parathyroid also. Then there is a inferior thyroid artery for the thyroid gland itself. For the thyroid gland there is a superior thyroid artery and there is an inferior thyroid artery that supplies the inferior parathyroid. Now the superior thyroid artery, it is a branch of, you can say carotid, common carotid. You can directly say, okay, common carotid, or you can say carotid artery. And this inferior thyroid, this is a branch from the thyrocervical trunk, which is arising from the arch, aortic arch, okay. So the inferior thyroid artery and the superior thyroid artery are the main two branches which supply the thyroid. But when you consider about the venous supply, here I will mark it out. There is a superior thyroid vein and there is an inferior thyroid vein. So the superior thyroid vein is directly draining into the internal jugular vein, just like the common carotid artery. There is a vein which is draining the whole of the venous blood from the head and neck region. This is the internal jugular vein. And inferior thyroid vein, it is directly draining into the subclavian veins. Some of the textbooks, they are mentioning it is the subclavian veins. Regarding the lymphatics, so lymphatic supply, what happens is, in case of the thyroid gland, it is draining into the omohyoid group of lymph nodes. Omohyoid muscle is very near to this, and the jugulodigastric group of lymph nodes, jugulodigastric. It is actually not the omohyoid, it is the jugulo-omohyoid. And basically both of them into the pretracheal group of lymph nodes. So this is the pretracheal group of lymph nodes. So this is basically that the lymph nodes in this, according to the structures which are found here, they are named accordingly. This omohyoid is a muscle, so jugulo-omohyoid, jugular vein, internal jugular vein is there. So basically the group of lymph nodes are also called as jugulo-omohyoid group of lymph nodes. Then there is jugulodigastric group of lymph nodes, which is very near to the muscle which is called as the digastric muscle. Okay, it is somewhere here, these group of lymph nodes. So this is the omohyoid muscle is somewhere here, and the digastric muscle is somewhere here. So basically in these group of lymph nodes, the thyroid gland is draining and the parathyroid gland is also draining into the same stuff. Okay. So moving on to the next part, that is the thymus. The thymus gland, actually, this thymus gland, it is basically a gland which is located in the chest, as I have already told you. So the thymus gland is a gland which is bilobe. They are telling it is bilobe. This is one lobe and this is one lobe. and the bilobe structure is present just behind the sternum. So the location is behind the sternum, and the position, I think you remember that there is something which I have explained to you as mediastinum. That is the area between the two lungs in the chest. Okay, so from both the sides, this middle area which has been marked here, this middle area, it is called as mediastinum. Mediastinum has been divided into number 1 superior mediastinum and number 2 inferior mediastinum, and I have already told you, some of you will remember, I know, that the inferior mediastinum has been divided into anterior mediastinum, middle mediastinum and the posterior mediastinum. So the important thing here is that it is the thymus gland, some of them they are saying that it is positioned in the superior as well as the anterior parts of the mediastinum. Okay, so just behind the sternum, and in the upper part, maybe in the manubrium part, which is belonging to the actually superior mediastinum, manubrium bone. So sternum and the manubrium bone, you will find this thymus gland. So thymus gland, the important thing is that it weighs approximately 20 to 37 grams. That is the highest weight which is attained during puberty. It is written also. So thymus gland, it increases in size till puberty. Okay, and after puberty it decreases in size. After puberty, that is in adult, it decreases in size. Okay, and it attains the size of almost 10 grams. So in the cadaver, actually what we have seen is the thymus, just behind the sternum, we see fat tissue, and we are unable to find the thymus as such in the cadaver. So in fact, I would like to say that in the dissections that I have done till now, I have not found the thymus except for certain fats and other kinds of tissue. The thymus is almost degenerated in the death, and the time we dissect, this has been totally obliterated. We do not see it because the cadaver, it is kept stored, and after some time only, maybe few months, if we take it out for our dissections or our studies. So basically at that time, some of the things, these are lost. So one of the things which is lost is the thymus gland. I have not seen it. Just because of this, number one point is that it is found maximum cadavers are adults. In the adult cadavers already it has decreased in size, and moreover it has been kept and stored after being dead for a couple of months, and that is why the thymus has totally regressed or degenerated. So basically the thymus gland is important from the anatomical point of view in just one thing, that the microstructure or the histology, it is very important, because the thymus gland, as you already know, the function of thymus gland is basically the training of the T lymphocytes. We have got two cell clusters. One is the B lymphocyte. You must be knowing that both from biochemistry and from physiology also, that the B lymphocyte, it is trained, the B lymphocyte, it is giving rise to the plasma cells also, and this has been asked in the question. And the plasma cells, they are basically trained somewhere in the periphery. Basically this is found in the bone marrow. This is mainly found in the bone marrow, and the training is going on, and the production of antibodies is carried on by the B lymphocytes in the lymph nodes and other reticular structures which are related to the production of the immune response. But the T cell is related to the cell mediated immunity, they are saying, and the training of the T cells is going on in the thymus. So thymus is very important structure from the point of view that they are basically the inborn fetus, they are not having a very good cell mediated immunity except the passive immunity which they get it from the mother. So cell mediated immunity is basically developed during the ages, and this is the training program is carried on in the thymus. Thymus, as you have already seen, it is derived from the same pharyngeal pouches through which the inferior parathyroid is developed, right? Inferior parathyroid and thymus, same. That is why inferior parathyroid, the position is in the inferior pole of the thyroid gland, because it has been carried on by the thymus and it was left out in the inferior pole of the thyroid gland. Okay, and the thymus, it regresses down and it reaches the mediastinum. In the thymus, what happens is the lymphocytes, they are coming from the lymphocyte producing organs just like a bone marrow, and the training process is going on. Okay, so moving on to the slides. The thymus gland, the molecular structure of the thymus gland is very important. This molecular structure is very important. So basically what I have to tell you in this is that it is, the thymus gland is basically also called as mucosa associated lymphoid tissue. This thing is very important now. And the type of cells which are found in this thymus gland, these are called as reticuloendothelial cells. Reticuloendothelial cells. Okay, so there are several types of reticuloendothelial cells. Type 1, then type 2 reticuloendothelial cells, type 3 reticuloendothelial cells, type 4 reticuloendothelial cells, type 5 reticuloendothelial cells. But basically the thing which I have to insist is that the reticuloendothelial cells, they are separating the thymus gland into a cortex and a medulla. Here in this case also it is not very much distinguishable, but the ones which are present in the outer and inner part of the cortex, this is the outer cortex, and suppose this is the entire thing is the cortex, and this one is the medulla. These are the two layers, and the outer cortex, this type 1, and the inner cortex, this type 4 reticuloendothelial cells are found, and the type 2 and type 3 are interspersed. So what is basically this type reticuloendothelial cells? These are basically the cells which are surrounding the T lymphocytes, and these are providing some kind of barrier so that the lymphocytes, they are not exposed to blood. So what will happen if they are exposed to blood? They will be directly exposed to the antigens, and these are naive cells. Naive cells means they are newborn. They will be trained that this one is an antigen, this is our own, this is an antigen. So they have to, they have to be they have to be taught that these things, these are not foreign, and these things, these are foreign. So for a T lymphocyte which has not been trained much, what it will do is it will directly start an immune response, a T cell mediated response, when it has not been trained much. So there are diseases which are implicated because the barrier is broken between the thymus tissue proper and the blood. So there has to be a definite barrier in which the newborn T cells are not directly exposed. They are first maturing, they are taught, and they become mature. Once they are mature, they are leaving this thymus gland. Okay, so the process of maturation of the thymus gland, of the T lymphocyte, is going on in this thymus gland. So what happens is, these reticuloendothelial cells, the important function of them is to make a barrier and to train them also. Okay. Now the very important characteristic which has been found in this case, that the thymus gland, it is having certain tissues which has been, certain landmarks which has been found in the histological point of view. This is called as the Hessel's corpuscle. I will show you in the slide also. The Hessel's corpuscle is nothing but reticuloendothelial cells which has been arranged in the form of whorl. Okay, so this is also called as rose. This is also called as the appearance of a rose that you see from above. So this is a rose petal kind of appearance. In rose, the petals are arranged. Petals means the leaflets of the rose. They are arranged in the form of a whorl, right? So this reticuloendothelial cells, basically type 3 and 4, type 3 reticuloendothelial cells, they are arranged in the form of whorls, and this is called as the Hessel's corpuscle. Okay. So this is a characteristic point which is to be seen in the microscopic slide. Why I am telling this? Because this is to identify whether this is thymic tissue or not. থাইমাছৰ এখন স্লাইড দিয়া থাকিব, এখন লিম্ফ নোডৰ স্লাইড দিয়া থাকিব, how to differentiate, although there are many other things also, but thymus T lymphocytes and B lymphocytes cannot be differentiated just with the help of appearance. Both of them are same. So T cells and B cells are there in lymph node, T cells is there in thymus. You cannot differentiate this is T cell or B cell. So basically we have to look for some other important things. Cortex and medulla that is present in lymph node also, that is present just because the thymus gland is very big also, so medulla some part may not be visible. So but basically the important thing that you have to see is that the reticuloendothelial cells, they are arranged in the form of a whorl, and that thing is very much visible in the thymus gland, and that thing is called as the access corpuscle. It has been described as the access corpuscle. So moving on to the next part, they are considered to be in the development of the T cells, which I have already shown to you. The important thing is that the diseases which are related to the thymus gland is number one, the thymomas. The increased size of the thymus gland, that itself is a carcinoma. So carcinoma is common for almost all the glands, of course. So carcinoma, thymomas, these are important. These has to be resected, and in certain cases there is from the DGR syndrome. This is a cluster of different kinds of symptoms which has been grouped together as DGR syndrome. Basically because of the abnormality in the chromosome 22q11, and along with the absence of thymus gland in DGR syndrome, there is also presence of other cardiofacial deformities which is associated with the DGR syndrome. The last thing which I wanted you to remember was actually this important point. This is the adult onset autoimmune response. In certain cases when this blood thymus barrier is broken, then this will lead to Graves' presentation. Okay, so Graves' disease is also related to the thymus gland, in which there is auto response to the own body's antigens. That means all the things which are, all the cell products which are secreted by the body, or certain things in the cells, surface of the cells, that itself may be considered as a foreign body, because the thymus gland, the naive cells, the newborn cells which has not been trained, has been released into the blood. So that will create a immune response, and that is the associated applied importance which is related to the thymus gland. Okay, so we'll be seeing in the slide, if at all possible. In the next class maybe I'll be showing you the slides. Okay, thank you.